Today's focus is going to be on new tests and treatments. I'm Deb Giorgi-Guarnieri. I'm also known as Deb G-G or Dr. G-G. I'm a private practice psychiatrist in Williamsburg, Virginia, in the United States. My special interests are in treating psychiatric patients with complications of long COVID and vaccine injury. My research, however, really focuses on restoring the DNA repair mechanisms in the brains and bodies of people who are virus and vaccine injured. I'm here tonight with Professor Andrew Shaw from Exeter University. Dr. Shaw is the CEO and founder of Atomarker. He has developed antibody tests that you will learn more about during the webinar. I'm going to go ahead and start by saying that first, people wonder, how do we work together? Well, we've both noticed that different people have different immune responses to COVID and to the vaccines. Professor Shaw measures antibodies and the quality of antibodies. I draw screening labs from your classic everyday labs to determine spike antibody numbers, cytokine responses, and neuroendocrine issues. Here in the United States, you can run up to your local LabCorp and get labs done. But if we can start now, I'd like Professor Shaw to tell us a little bit about his antibody tests. Professor Shaw.
Hello, Debbie. Hello, everyone. Thank you for joining us. And so the idea of the presentation this evening is it's interactive. We can ask questions, but I'd like to share some information around how the test works because we have just collected from America the first cohort of long COVID tests, and we're now able to collect many more from America and make the test widely available. So for complete clarity up front, all but 4 of the patients in the cohort of 52 from America have given their consent for us to use the data for presentation in this webinar and in a subsequent publication. So that's really important. And I have the ethics approval from my local university biosciences ethics committee to use all the samples with the approval of the patients for the benefit of understanding COVID and long COVID. If you were to ask a question, can we try and be anonymous? So your US number, if you're in the cohort, would be sufficient. Otherwise, just ask an anonymous question and we won't give your name away. It's also really important to remember I'm a scientist, and you need a doctor to turn the science into medicine. And so there are many things around the back of the science that the doctor needs to understand around the rest of the patient questions. And financially, of course, I'm the CEO and founder of Atomarker, and it's a spin-out company for our research group at the university. So just to make sure we're on the same page, when you get sick from a viral infection, and the SARS-CoV-2 infection in particular, it comes in through your nose, probably, maybe your mouth, and enters your body. And that triggers a period when you're asymptomatic and you don't know that you're carrying it. And then after that, when it has found the parts of the body it's going to bind to, so-called receptors, then it triggers this infection phase. When you know about it, you have sore throat, you have fever, all those symptoms associated with the really awkward part of the infection. And some of those symptoms are ongoing, but over time, over 2, 3, 4 weeks or so, they should clear up. But then after a period of about 12 weeks, and the definition is now out to 20 weeks, some patients are beginning to maintain the symptoms, and they have problems in their lungs, they have problems in their digestive tract, they have problems in their hearts, leading to more than 250 symptoms associated with long COVID. Is it because of a viral reservoir? There's an uncleared virus, and we come back to that as a possible cause. Is there autoimmunity? Have for some reason you generated a strange immune response to the infection? And is that causing endothelial destruction, inflammation around the body? And it's this region in which the long COVID patient types need to be found. The reason why it's such a difficult virus is because this is the virus. It's about 1,000th of the diameter of your hair, so it could hang out anywhere in your body, and that's part of the problem. It docks with this group called the spike protein on the surface of the virus, and that's what it looks like in its pre-docking form. And this is the central character, but it binds to these ACE2 receptors, which are all over the body, and they're in your heart, they're in your lungs, they're in your muscles, or in your blood vessels, and that's why it's such a dangerous virus? Because the entry point is simply everywhere. And so the basic biology is how do we stop the virus from getting in, and how do we attack spike protein? And how do we get rid of it? That's the really important part. Imagine the virus is floating around in your body somewhere. If you getting over the infection properly, then you send in antibodies to find the virus. This sticks here. Then the back of the antibody sticks to these other complexes in the white blood cell, and that is the process that leads to clearance from the body. If this doesn't stick, either because it doesn't bind to it at all, or because it doesn't bind for long enough, doesn't stick for long enough, you don't clear the virus. And for me, that's the focus of our test. We've looked at the antibody numbers that you've made, and we've looked at the antibody quality. The problem has been that it's a moving target. So the blue color here is the Wuhan spike protein. This is the red dots here are the ones that have caused mutations in Omicron BA1. This is in BA2. See, it's different. It's moved. It's changed. And XB115 is yet another variation here. So you've got very strange moving targets. The problem is, if you make a good quality antibody to this part in BA1, and it's not there in XB115, this antibody doesn't work. If it doesn't work, then you don't clear it. And the antibody complex doesn't last for 2 hours. We've learned from measuring recoveries, antibody levels in patients that have recovered. Then the complex falls apart, and I argue that the complex is not, that the virus is then not cleared from the body. So what we've done is
Professor Shaw, do you know if the antibody isn't cleared, if the virus isn't cleared from the body, do the antibodies eventually fall apart? Do we ever have just spike protein, or do we always have the spike protein antibody complex in our body?
If the antibodies are not sticking, then either the spike is on the surface of the virus, and so it's freely moving and not cleared at all. Or if it's shed from the virus, then the complex won't, the spike protein itself will be floating around. Or if you're making the spike protein because of some autoimmune response, then the spike protein will also be moving around freely, and the antibodies might collide with it for a while, drop off, and clearance doesn't happen.
So just to be clear, you can have a spike protein antibody complex, and you can have just spike protein in your body. Is that correct?
I think that's likely, yes.
Mm-hmm. Which I think is important for measurement purposes. Like, do we want to measure just the complexes, or do we also want to measure how much free spike protein is in the body?
And that's a really important question, because the spike protein is clearly toxic on its own. And if we can't clear it because the antibodies are not binding to it, then you have a problem, two problems. You're not clearing the virus, you're not clearing the spike protein, and the virus, and both effects are happening in your pathology.
Yeah.
So what the test does is we print down the proteins here from the different spike proteins from the different variants, and we count the number of antibodies that land on those spike proteins and give you the spectrum. You can see there then how many antibodies are sticking to the variant. And then we also do a measure that works out how stable it is, how well it lands on the surface, and how well it sticks. And so what you get is, these are your antibodies, this is your antibody spectrum. So this is the spike protein from all of the variants. And these are the antibodies sticking to the surface. So you can see some good antibodies here, a good antibody concentration here, and some bad antibody concentrations towards the back end. And this is the quality. So this is 50% of these antibodies stick for more than 2 hours. Same for this one here, same for this one here, but these antibodies don't stick very well at all. So we've calibrated that against 88 control samples, and we're now looking prospectively at the American cohort of patients that came through. So when you've had your results back from us, you would have had both of these pictures, and you would have had this table of numbers telling you whether you're above or below the parts of the reference ranges for the normal patients. And so what we're trying to do now is classify patients based on the onset of their symptoms, because let's say here in the middle of 2022, you got an infection and that's when your symptoms started. It was Omicron BA1, for example. And if there's a gap, if that correlates with a hole in your antibody spectrum, we would argue that that gives you a persistent virus risk. And that virus then needs to be cleared from wherever it is in your body. Remember, those ACE2 receptors are all over your body, and that can then be used to explain many of the symptoms that occur in the long COVID syndrome. We've also found that people's symptoms occurred with vaccine dates. And we can also see, for example, that in this case here, that an early vaccine to the early variants has triggered a very large antibody production. And this came out of the cohort very clearly, with 200 milligrams per liter of antibody against, for example, the alpha variant here. If that corresponds with the vaccine date, that hyperimmune response may be due to some vaccine injury. But clearly this is a very different response to the hypoimmune response. And so now there are two types, at least, of long COVID patients. What we did is an analysis looking at 150 long COVID patients against controls, and found a classification that says, in fact, 65% of long COVID patients seem to be immunocompromised in some form with gaps in their spectrum, and so at risk of a virus. And if that corresponds, if a gap in their spectrum corresponds to the known variant in the waveform, then you can argue that variant was persistent. About 10% of patients are hyperimmune, so they're well up in the upper 10th percentile of the distribution of the normal range of patients, and they're making really high concentrations of antibodies, and all of them are of good quality. It's as if this patient is making antibodies at the maximum possible speed and polishing them to the maximum possible quality. And this is a very active state for the patient. But there are 25% of patients for which they seem to be antibody competent. There are no problems with the quantity of the antibodies, no problems with the quality. And as far as we can tell from the antibody spectrum, they're okay. So
you could say approximately 25% of people do not have long COVID, or 25% of the people with long COVID have the proper antibody complement?
So these are people that are presenting to the doctor with symptoms that have lasted for more than 20 weeks and may have the right classification, but I can't tell from the antibody spectrum whether they have an hyperimmune response or an immunocompromised response. So we've now completed the first wave in America, and we've made the test available to the rest of the US.
Okay, so like I said, for my labs, you run up to the LabCorp and you grab your labs. How do the people in the United States get these tests?
So we have now validated this collection device, and it's a Tasso device, and we now know that our test works properly from that. So if you go to our website or contact our customer care email address, we'll arrange for this to be sent to your house. It's really easy to use. You put it on your arm. You tap the button on the back, and it goes through your skin. There's a small vacuum in it, sucks the blood out, but you won't notice it's happened. It's really easy, and an amazing piece of technology from Tasso. Well done for developing that. We'll know we've sent it to you. We'll arrange to pick it up from you. It goes down to our distribution lab in Alabama, and then the samples are sent over to us for analysis. So it's really easy. In the price of $400, the shipping to your house of the Tasso, the collection of the Tasso device, the shipping to Alabama and the shipping over the UK is all covered, leaving a test price of around $275. You can also send a standard blood draw. You just need to ask us what protocol to use, and we can arrange for your doctor to do that and then send it back down to Alabama as well, and then we will ship it back to the UK. So it's very easy to use, and we're now collecting, I think we've had now more than 20 inquiries for this second wave of testing. So the logistics seem to be working really nicely for the US.
Okay, so I see on your slide you have next interventions. And of course, that's where I step in. I have plenty of patients who show up on my door and they come into my office and they say, I've been sick a long time. What can I do? And, our labs will show high spike antibodies. Of course, we don't have a lab for high spike protein. Here in the United States, we have something they call IVIG, which I think is similar to what you're about to talk to us about. We also have sub-Q IG. And I wanted to mention like how my patients have done with that. So, for instance, I have a patient, she's in her early 60s and she has MS. And her neurologist has been giving her IVIG for the past year. And I know that seems like a lot, but that's the way he does it. I've been able to manage her psychiatric symptoms with a medication called Sunosi, which is a medicine for circadian rhythm disorder. So she sleeps and she has decent energy. Her depression and her anxiety are under control, but her spike antibody numbers remain over 25,000, and she still has absolutely no melatonin in her system during the day. So that's a person that's had a treatment in the United States, but I'm not sure it's really addressed what we need to address. And then I think I've told you about another patient of mine who's a 40-year-old woman who suffers with brain fog and chronic viral infections. And she's been taking the is it called Zembify, which is a sub-Q IVIG. And she's stopped getting ill, but she continues to have brain fog and she continues to have high spike antibody numbers when we take her numbers. So tell us a little bit about the interventions you've been doing.
So I think the beginning now is that the cohort of long COVID patients is not one cohort. There are a number of long COVID types that we can tell from their antibody response. And these are some examples from the American cohort. This is one of the worst immunocompromised antibody spectra I've seen in the 550 odd tests that we've measured so far. This patient may have real problems in making antibodies full stop. They may have general problems that are more prominent in their being immunocompromised. And the doctor needs to understand that. If there are other measures and other parts of their medical history that explain that, that's consistent with them being immunocompromised. This took me by surprise. This is an enormous antibody concentration and some patchy quality, but some islands. And I couldn't understand why this was there, but that's what we observed. Turns out this hyper and immunocompromised patient has had PEMGARDA, and this is actually the antibody spectrum for PEMGARDA. So I'll come back to that in a moment. That's an example of one intervention. Here's another immunocompromised patient, more likely to have gaps associated in their spectra with particular variants. And here's a more conventional hyperimmune patient. So there is now a number of types of long COVID patient, which I think explains why some patients perform well in interventions and some patients don't. So those of you who've been tested, you'll see this from the numbers. You can see that you've got high antibody levels. You can see that we've notified that as being above the range, the upper quartile, and some below the upper quartile or within the normal range. And here we are in the colors you'll see on your report as well. Here we are below the 25th percentile, above the 90th percentile for quality and quantity. So you should be able to work out whether you're immunocompromised or hyperimmune. And for the first time in the American cohort, I saw both. And this is quite surprising. So this patient here has very high antibody levels to the early variants, but really poor quality antibody level, poor quality antibodies and low levels to the later variants. And this can be explained in terms of how the antibody binding to the spike protein, but it's nevertheless a new discovery from the American cohort. And that has really interesting complications, I think, for their interventions. So just to back up for the cohort stats, we've got about 56% of them are immunocompromised. That's consistent with my initial study within error bars. About 14% are hyperimmune, again, consistent. This new group of people that are 17% one or the other, that's new, and 12% are normal. Some elevated CRP levels as well. So I think this process means that we have a heterogeneous cohort. Going back to the cohort, we're going to come back to you and ask you if you can provide us with your IC10 classification, ICD-10 classification, so we can see whether this works, whether we can identify the onset of your symptoms with a gap in your spectrum, and we'll put that as a classification. We'd also like to know what your major symptoms are, and critically, what you've tried. Now, this is your point, Debbie. I think this is just a list of 25 drugs that patients have tried in our community, and they don't know whether they are hyperimmune, hyperimmune, a mixture of those, normal in antibody levels. They don't know. And the outcomes of all these interventions and now depend on your antibody and your long COVID type. And I'm beginning to track which of these interventions have been useful for some patients. So I think that goes back to the patient stories you've been talking about. Would some of the antibodies, the IgG, work for them? Could they work for them? What's a good mechanism for that? Would remdesivir work for them for a persistent virus antiviral? I think this is now the critical part of the story for long COVID.
This is a good place for me to jump in. So, I'm a traditional doctor. I went to med school. I do what they tell me to do. I know all the standards of care. I take care of patients the way I was taught to take care of patients. Then came COVID, and I would have patients come into my office and say, my meds aren't working. And I would think to myself, why wouldn't their medicines be working? And we would talk about it. We would try some other things, and nothing seemed to work. Well, traditional medicine, they look at the symptoms, they treat the symptoms with whatever medicines we have that are known to treat the symptoms, and then we assume that the disease process is halted or that it's slowed down, and that takes care of the cause of the disease. What we've learned with COVID is that it's a progressive illness, that it keeps going even when we treat the symptoms. So for instance, I see on your list of medicines, valacyclovir. So Valtrex, which is what we call it in the United States, we give all the time for people with chronic Epstein-Barr virus. And most of my patients show up with chronic Epstein-Barr virus. In fact, I have chronic Epstein-Barr virus from having, well, I had COVID before anybody knew what COVID was. I had it in April of 2019. And I can tell you that while I'm taking it, I feel better. But the minute I stop taking it, I feel worse. And what I've learned is that you can actually withdraw from antivirals. You can actually have what we call long COVID. It's almost like you're having a withdrawal from having the virus every 4 to 6 weeks, or having symptoms of the virus every 4 to 6 weeks. So I started to turn my research toward repairing the DNA mechanisms we know have been damaged. So what happens with that? And I'm not going to tell you I know all the answers, but I'm going to tell you what happens when we took simple over-the-counter powders mixed together that were meant to repair the DNA. So my very first patient shows up. He'd had COVID in February of this year and gained 25 pounds after having COVID on a GLP-1 agonist. My labs showed that he had low testosterone, low cortisol, and low T3. His spike antibody numbers were greater than 25,000. In fact, there were so many, they weren't going to actually keep counting beyond the 25,000. So he took these 3 of the powders. There's 5 that we use in different combinations, but he took 3 of them in the morning between 7 and 10 a.m. He would put 3 in 8 ounces of his coffee. And then again around 2 o'clock in the afternoon, he'd put 3 in 8 ounces of his coffee. And I thought, well, it's going to take a long time because these things are just traveling around the body and we don't know when they're making it to the target cells and when they're not. He came back 8 weeks later. We repeated his lab. His testosterone was normal, his cortisol was normal, his T3 was normal, his spike antibodies were down to 14,500, and he had lost 20 pounds. So that really encouraged me to keep working, keep looking at things that work from the inside out. So I see the repairing the DNA mechanisms as about as close to the damage as you can get. I see the next step out as using these immunoglobulins, using your IVIG and that type of thing. So my question would be, and Professor Shaw maybe you can weigh in on this. Should I be doing both? Should I be doing the powders and should I be doing the IVIG?
So what I can say from the test is that I can see before and after changes in the antibody spectrum. So this is a this is a PEMGARDA intervention from a patient that was on the cohort. You can see that she was hyperimmune, very high antibody level here, and a doctor gave her PEMGARDA, and the antibody concentration got up to nearly 10 times, and very quite close to the safety limit for antibodies. And you can see a before and after. So I don't know how that translates into the improvement of symptoms, but I can see that the immunochemistry has changed. The immunology profile has changed. And just zooming in on the PEMGARDA, you can see it has really strong antibody levels to the early variants, and there's a bit of a patch to a few of the later variants. And so if this antibody were associated with a gap in your spectrum and the onset of your symptoms, you could use this to fill the gap, and then you have to wait. Then we know that we've repaired the spectrum or plugged the gap in the spectrum. How does that translate into the repair pathway? How does that translate into the recovery pathway? And I think some of the medical interventions for the management of the resets of the body, of the management of the symptoms, all those are really important. But I do know something changed. I just don't know how that translates directly into recovery. And especially this patient, this is a very strange patient. I probably, in my hypothesis, would not have given her the PEMGARDA, but she got better from being ill over the period of about 3 years to going to Paris for a holiday. And I sort of predict that when this is the PEMGARDA antibody, it's got a half-life around 80 days. Since she took the drug around Christmas time, I think it's possible that these antibody levels will begin to fall. And when this antibody level gets down to around this one in 2 or 3 half-lives, then her symptoms may return. And I wonder what's causing that. Why did the antibody mop up the symptoms now? But clearly at this level of antibody, the symptoms were present. And I'm wondering now whether this is the spike protein. And we've just received a nice philanthropic donation to invent a spike protein test. And the spike protein test, the spike protein goes through a number of phases during the cycle of interaction with the cell, but it starts off in this trimeric form, three clusters. When it's been around the cell, it falls apart into monomers. So post-infection from a virus, you might expect to see monomeric spike protein. Pre-infection on the virus, you might expect to see the trimer, and you would see the trimer from the vaccine. So now the new test is going to tell you whether you have natural spike or whether you maybe have spike derived from the vaccine message. So this new test might help us understand whether this patient is making spike protein as part of an autoimmune response or a vaccine-injured response, and then whether the PEMGARDA was able to titrate that spike protein out. Now, what is really interesting is the recovery of that patient was quite quick, within 4 weeks or so. So with the right intervention, then maybe the symptom journey is also possible.
See, that's a question I often get from my patients. They'll say to me, my symptoms are gone. Is my spike protein gone? And I don't know how to answer that because I know that your spike antibody levels might be lower or not growing the way they were growing before, but I never know if the spike proteins themselves are gone. I mean, we assume that if all of a sudden you have function back that you didn't have before, that the spike proteins are falling off of the receptors they're stuck to or coming out of the organs they're housed in. But we never really had a way of measuring that.
And I think the spike blood test might point toward that, with the caveat that if the latent virus or the spike proteins are being made in your brain, is that really reflective of the spike concentration in your blood? And I think there's a real sampling problem looking at various parts. I think of possibly plugging the gaps and then maybe repairing your antibody spectrum comes from a study here on a patient that was identified with gaps in their antibody spectrum around Wuhan, actually, especially quality of antibodies to Wuhan. So they had Eversheld, which was a very early monoclonal antibody, and they had it. And you can see here with the Eversheld going in that improved the quality of the antibodies in the patient, and they started to show improvements in their symptoms. We gave them repeated doses of antibody to get the antibody concentration high enough in their body so that it perfused around their brain and could get into their brain where major brain fog problems were occurring, and they had their brain metabolism was rather low. And they started getting better, so that my patient who was bedbound ruined my time course measurement by going to Greece on holiday. And so should have been a data point in here. But we got the antibody concentrations up to 120 milligrams per liter and high quality antibodies, and that began to perfuse through his body and he began to get better. And the bit that I think is really interesting here is at that level, you can see the signature of the Eversheld in their blood and also the signature of the Eversheld in their cerebral spinal fluid. And I think that's why ultimately his migraines and brain fog and all the other symptoms he had improved. It wasn't the whole story. He needed lots of additional sort of system resetting afterwards, but now he would claim that he's completely recovered. So there is a scenario where you can plug the gaps in your antibody spectrum, and that then removes a persistent virus.
You know, I have a very different approach because I'm in an independent practice and I don't have people telling me what I can and can't do. So a lot of times what I'll say to a patient is, let's try this. So what I do is I follow spike antibody numbers, and when they get under 25,000, when I actually can see that you're not building them anymore, then I would say that might be a time to try again. But as long as they're very high, if you're still symptomatic, I don't see how doing the IVIG is going to help. That's my patient. She does the IVIG all the time, and she has had some symptom relief, but her numbers are huge. She still has tons of spike antibodies in her body. And, you know, she says to me, well, what am I supposed to do to get it down? And no melatonin. And, you know, you need melatonin. Melatonin in the brain is a very strong antioxidant. And this is a woman with MS. So we have talked about her taking a break from the IVIG until I can see a number in her spike antibodies and then retesting. So I guess what I'm saying is you might want to try a different approach.
The theory behind IVIG is that the external antibody switches off your antibody production. So if you were sitting up at really high antibody levels that were autoimmune, the IVIG would, for a period of time, switch off your own antibody production, and that might then lead to some relief. But I think it's likely to. The Novavax intervention, this is a long COVID patient with a poor antibody spectrum, as you can see. They then had Novavax, which is available in America now, I think. And
Yes.
the protein vaccine gave them a good response across the antibody spectrum. They had 3 jabs a month apart to get the antibody levels up, and that too produced a recovery. I know that long COVID patients don't want to go anywhere near vaccines, but there is some good science that shows that it changes the antibody spectrum. But no, I don't think you can find an antibody easily to work out that far.
So I do treat differently. So I have very, very few patients in my practice who test negative for the nucleocapsid, but still have high spike antibody numbers. And so for those patients, of course, we wouldn't do any antiviral type of things. We would focus more on where the deficits have landed. Because again, from what I understand from my reading, the very basis of the problem is what happened to the DNA repair mechanisms. So of course, if it wasn't injured by a virus, it was injured by a vaccine, your inflammatory markers will be different. Your cytokines will be different. And that would change what medications, like traditional medicines, we would use and what supplements we would use. Patterson, I don't know if you know who he is, but he did the cytokine profile, and he talked about which cytokines seem to be higher in the vaccine injured versus in the virus injured. And so for me, I do a panel, but he does a more extensive panel, and that might help you with what your inflammatory markers are and how you can intervene.
Can we take a question from Nancy Klimas? Is that possible, please?
Sure.
Thanks so much. And this is really a great presentation, and I'm really fascinated by your treatment protocols. Andrew, I was wondering if you could explain to me the clinical relevance of variants that failed to respond if you don't think they saw them. I mean, how do you know in your variant assay who's hypoimmune if they responded to some things but not all the things in your platform?
So I think that the link here between the symptoms and the spectrum is important. If it turns out they have a risk, so the early Pfizer vaccine had a beta hole, for example. It was a well-reported hole. If you're not going to walk into the beta variant anymore, then that's not a problem for you. And I think aligning the symptoms with the holes in the spectrum, or aligning the symptoms with the onset of hyperimmunity, this is an important classification process. If this doesn't line up, sorry.
Yeah, I mean, for me, when we're talking about using monoclonal antibodies or vaccines or anything like that, it's more about identifying the patient that could respond to that therapy. You know what I mean? So, like, with the monoclonals, that some of them, have very limited, more recent variant coverage, but pretty good coverage back in the day. So if I knew somebody had long COVID starting from 2021 or 22, and they had, antibodies that suggested that was the variant that they were dealing with, that kind of makes sense to me that that's a person I'd stick into a protocol like that. I mean, could it be used to screen someone into a protocol versus screen them out? You know what I mean?
Yeah, so I think if there was a gap in their antibody spectrum that coincided with a hole that could be filled with, say, Evershed or with Sipavibart, that gap around these early Omicron variants here, for example, could be filled. That would be indicative, I think, of giving them the monoclonal. But the question is how much and what does recovery look like? If you've got to get it into their brain, is it a 3-month recovery journey? Is it a 6-month recovery journey? I don't know. And do they need any other symptom management alongside that? So again, I said earlier, I think I can measure a change. How that change begins a recovery journey is another matter somewhat.
Yeah, I appreciate that. Your new spike protein assay that you're working to develop, would it be variant specific?
We will be able to tell the difference between pre and post Omicron.
Yeah.
Because the antibodies are available for that. And I think that that's as good as we can do at the moment with the available materials.
Thank you.
I had hoped that being sort of the guest host on this today, I would be able to show people how maybe there are times that we need to work together between the research and what we're doing clinically, and anything we can do to increase that communication, whether it's, different countries, different types of doctors, therapists, scientists, researchers. I think it can only get us where we need to go faster. So I highly recommend that you talk to people, you do what Robert has done for me, introduce me to other people that are doing things that I'm doing, and keep trying, because the body is an incredibly well put together organ situation, something we in medicine don't have. We can't create what the body can do. So we'll get there if we all talk to each other and we all make sure we're doing things we should be doing, not things we shouldn't be doing. So I encourage you all to keep trying in your journey, and I am almost positive we will have this together in the next 5 years.
Thank you very much, everyone.
Thank you.